This is great, and not to be outdone. And I think maybe to bring, and again, you see, this is not really a decrescendo, if you will, but it is. We're talking about techno-evangelism versus technosticism, and maybe an agnostic is going to come up and kind of give us a broad-based overview about what we really need to measure and how we can do it, and maybe a diagnostic and therapeutic lingua franca. And while it pains me to say it, I can't think of anyone better to do this than my Flomigo and frenemy, Joseph Loren Roman Mills Sr. Can you please help me welcome Dr. Mills?
David has a way of giving you left-handed compliments. So the title of this was the Flows and Cons of Perfusion Assessment. So should you measure it? Is it a good thing to do it? And what are the downsides of it? And I've added to that two subtitles. Why bother? And we've heard yesterday how it's usually obvious when a patient has ischemia, they don't have a pulse, you just go fix it. And then to try to demonstrate to you that there's a difference between anatomy, which is what you get off of some imaging studies, and actual perfusion. So the first couple talks have been great. I mean, they're futuristic. And I think it's great to plan for the future and to look for the future. But we live in the present. So what do you do now when you see these patients? So I'm going to try to cover that. Well, I told I had no trouble with the clicker yesterday, but I am today. There we go. No conflicts of interest to disclose. So this is the brief introduction. So if you heard the talks yesterday, when you're assessing the limb, so you have a limb, a patient, and then you're going to get to the anatomy, I think it's really important that you document ischemia. Now, why is that? Well, this is the why bother part. Ischemia is surprisingly frequently misdiagnosis in the evaluation of patients with diabetic foot wounds. You'd think that would be something we'd always check for. In practice, that doesn't happen. So unless you have a mandatory assessment of perfusion and you routinely incorporate it into your management algorithm, it'll keep getting missed. So make it part of your pre-fight checklist. So what's the data that it's missed? Well, this is an old paper. I wrote this with Spence Taylor and Clark Beckett back in 1991. It's actually been quoted a lot of times. I get called by attorneys who want me to testify against people who miss perfusion or miss infection. I don't do that because actually that's the standard of care right now, is these things are frequently missed. But the two most common things that were missed in our practice when we were in the Air Force, when patients finally got sent in with diabetic foot wounds, was either infection hadn't been recognized at all or grossly underestimated, and ischemia was totally missed. So you say, oh, this is a small series from a bunch of guys that were in the Air Force, so it's not like that in the real world. Well, we heard from Nick Scopper yesterday in Eurodial, a very civilized part of the Western world, 45% of patients had not undergone a vascular workup for PAD. That's pretty surprising. So you should measure it. So there's two different issues. One, is there a perfusion deficit? And then two, once you decide there is one, then you go looking for the anatomy and the lesions that are responsible for it. So how do you assess for a perfusion deficit? I think history and physical is really important. There's some simple tests that we all use, and there's some more complex tests which are already available. Then once you've assessed the perfusion, then you go for the anatomy. So that's the problem I have with why not just get an imaging study? You'll see where the lesions are. Well, you'll see the lesions, but that doesn't necessarily correlate with perfusion. Now, so simple things. Every patient you should examine, you look at them. You look at the foot. This patient has a large ulcer under the first metatarsal head, has classic motor and sensory neuropathy. So if you don't look for that, you're going to miss it. And if you just try to correct the perfusion on that patient and don't pay attention to the anatomy of the foot and the biology of the foot, you're not going to win. The bottom patient actually has an infection. We always listen. I do this on rounds. And so the cons of perfusion assessment are a patient will come into the hospital and the vascular lab's closed. So nobody wants to drain the foot or do anything to it, even if there's infection, because there's no vascular lab. Well, you can get a Doppler, and you can feel pulses. And if the patient has pulses, and particularly if you put the Doppler out between the web space and the first and second toes, and the flow is clearly pulsatile, biphasic, you can hear it easily, that patient can just be drained, and you don't have to wait for the vascular lab. And then always feel for pulses. So I think the thing that vascular surgeons have as an advantage is if you examine every patient, so you examine their abdominal pulses, their iliac pulses, their femoral pulses, their popliteal pulses, and their pedal pulses, and you do this on every single patient over a long period of time, and then you correlate that with vascular lab studies, you get better at it. So I think everybody that sees these patients needs to do this. Now, this drawing is from Dr. Andros, and I only bring this up. You're going to think I'm crazy, but we had this patient with a small, big toe ulcer that just wouldn't heal. The patient was immune suppressed, and the forefoot perfusion was bad. On the non-invasive studies, the toe waveforms were all flat. And so that was what I heard when I went to see the patient. And I went to see the patient, and he didn't have a dorsalis pedis pulse. But he had a clearly palpable anterior tibial pulse, and all the way down almost to the ankle mortise, and then nothing. And then when we angioed the patient, he had this focal lesion and the only runoff to his forefoot, so I ballooned it. And his toe waveforms all got better, and his foot healed. Within 6 weeks, he'd had this ulcer for months. So I'm not advocating pedial angioplasty for every patient, but I'm saying if you correlate the physical exam with the non-invasive studies, you can figure out where the lesion is and figure out what you might have to treat. So pulse exam is important. Some kind of flow measurement is important, but pulse exam alone is not enough. So this gets back into the limb status. How can you measure? What do we have, and what data is available now for the things that we do have? Well, we have ABIs, we have toe pressures or toe waveforms, we have transcutaneous oxygen, we have skin perfusion pressure, and we do have some data for indocine and green angiography. So this is a systematic review that's going to come out in the JVS. It's part of a working group. So there's a couple working groups for the Society for Vascular Surgery. This particular one focuses on diabetic foot healing. And you can see that the predictive value of ABI and transcutaneous oxygen is not bad. It's not perfect, but they're pretty good. So we have tools already now that help us. And then if you look at toe systolic pressure, if you remember from the Wi-Fi classification that some of us talked about yesterday, almost every study that looks at it, that looks at toe systolic pressure, you get a cutoff of about 30. So if your toe pressure is less than 30, you have a very low likelihood of healing. So don't you want to know that? When you see a patient up front, wouldn't you like to know high likelihood of healing, kind of moderate, and then very low? Because these are the patients you need to focus on. You don't want to miss those patients because those are the ones that are going to get infected if their wound's not dealt with, and you're going to lose. Same thing with TCPO2. Fortunately for Wi-Fi, 30 works for TCPO2, and 30 also works for toe pressure. So that's a number to remember. And this is a large group. So Falia's group with Giacomo Clerici is a good friend of ours. One of the largest series in the world of endovascular therapy, primarily tibial disease. And pretty much if your toe pressure is over 30, you pretty much heal. Now, some wounds with toe pressures less than 30 will heal. I get that, but that's a good cutoff to know. Same thing. This is great for Wi-Fi because if you use skin perfusion pressure, threshold's about 30. Now, that doesn't mean if it's 31, it's automatically going to heal, and if it's 29, it's never going to heal. But if you apply this to a large group of patients, it gives you a good cutoff. Now, what's the problem with these methods then? We have these methods. We have numbers that work. Well, there's a big problem with ABIs, and I'll show you that. And the problem is it's very good at predicting mortality. So if your ABI is low or your ABI is too high, you die sooner. But it's not as good at predicting wound healing. And frequently, since our disease has changed, in many patients you get medial calcinosis and you can't measure an ABI. Some patients even have calcified toes and you can't really measure toe waveforms, or they have missing toes or they've been operated on before. There's infection and the techs can't apply it. And then Dr. Montero Baker already talked to you about the difference between having normal forefoot perfusion, but you may have an ischemic heel. And then I've played with these a lot, but there's a lot of variability in how they're measured. The techs sometimes have a hard time with it. Room temperature affects it. Perfusion affects it. And then wounds can limit the ability to assess it. So just think simply. What we do with these patients, everybody gets a history and physical. We try to feel all their pulses. We use handheld Doppler, and we measure their perfusion in some way. And I am an agnostic. I think with the current tools we have, it probably doesn't matter which one you use, but you need to use them on every patient or you're going to miss things. So if you have a pre-fight checklist and part of your checklist is not to check if there's fuel in the plane, you're going to have problems. So why does medicine resist checklists? I mean, why shouldn't the perfusion be measured on every patient with a wound? It's easy. So then, if you look at our Wi-Fi framework, once you've evaluated the patient, their perfusion inadequate, then you go looking for the anatomy. And there's different patterns of disease. So we use duplex to start because we have that in the office. So if the patient has a normal femoral pulse, normal popliteal pulse, and their waveforms and velocities are normal all the way to the knee, you know they have tibial disease, right? So if you're going to do an angiogram, you can focus on the below the knee portion, get really good films. And if you're going to do an intervention, you know where the intervention is going to be. And for those patients, we stick a manograde. If they have long segment disease, that's useful to know because if they have a good vein conduit, which we also assess in clinic, then maybe the purpose of your angiogram is just to pick the target, and you're not going to try to do a heroic a heroic endovascular procedure. You need to get films that include all the way to the forefoot and lateral, at least 3 views of the foot, but a lateral foot is frequently the best view. And again, I made this sound simple, but there's going to be patients that have normal perfusion, mostly neuropathy with or without infection, and people with really poor perfusion. But there's a lot in here, and there's a difference in philosophy about what you should do there. Some people say correct it, always correct it if it's there. If there's any perfusion deficit, fix it. Well, if you have a moderate SFA stenosis and a toe pressure of 60, I'm not sure you need your SFA fixed to heal your wound. So those patients we follow closely, but if their wound healing stalls, we correct their ischemia promptly. So this is kind of the same concept as Wi-Fi in a different way, but if you kind of look at patients, they can have infection-dominant wounds. So if somebody has a puncture wound and they get gas in their foot, they had normal pulses before this happened, they don't have ischemia, they don't even have much of a wound, they're at high risk to losing their leg. Ischemia-dominant patient would be classic ischemic rest pain with no wound. Their problem is primarily ischemia. And then you have these patients with giant wounds with some ischemia and no infection yet or a lot of infection. You can kind of see how these curves move around. So we try to look at all of these factors. And a really important point is if you're treating a patient and the wound stalls or it doesn't get better, go back and reassess them, because the most likely thing is you're missing ischemia, or the endovascular procedure you did or the open procedure you did is failing, or there's infection that you've missed. So the toes start to look worse. The wound stalls, the granulation tissue's not making it. Don't rely on your previous assessment. Reassess the patient. Start as if you're seeing them for the first time. So I'll skip over Wi-Fi because we've covered that in depth. But basically, if you look at these scales of perfusion, and these aren't meant to dictate at what level you have to revascularize patients, although in general, people in grade 0 ischemia almost never need revascularization for the purpose of healing. And many of these patients, the severe ischemia grade, will require revascularization. But again, a small, tiny ulcer in a patient that's not very functional might be better off just being careful wound care. So it's not a mandatory, but it kind of gives you an idea of what likelihood of needing reperfusion is going to be. Now, what's the problem with our standard tools? Well, this is from our own series. Luc Jean showed a little bit of it yesterday, and Jonathan Brown's done this work with us. But this is our current practice. So 85% of our patients are diabetic. A quarter are already on dialysis. Most of them actually aren't smokers. 65% had ABIs that were greater than 1.4, so that doesn't help you very much. And 41% we couldn't get toe pressures, either because they had no toes or the toes were too swollen. So in general, about 30% we couldn't grade their ischemia in any conventional way using ABIs or toe pressures. So how do you measure blood flow in those patients if you think that's important? Now you're thinking, well, this is just a specialized practice. They get all the really hard patients. This is not real world. Well, here's real world data. This is from Nick Schopper yesterday from Eurodial, non-compressible leg arteries in a third of the patients. So that means in a third of our patients, the standard tools that we all grew up with that we applied to non-diabetics don't work so well in diabetics. So are there better ways to measure blood flow? Well, we have ankle brachial index, toe pressures, and don't forget waveforms. So the other thing I don't like about computerized reading of vascular labs is sometimes you can have an ABI of 0.7 or 0.8, and it's falsely elevated. And you look at the ankle waveforms, and they're monophasic and barely pulsatile. So those patients don't have completely incompressible vessels, but they have partially incompressible vessels. And if you just rely on the ABI and don't look at the waveforms, you're going to miss the boat. So you always got to look at the waveforms. And then the toe waveforms take priority. So if you have relatively normal ABIs and all the toe waveforms are flat or poorly pulsatile, that's not very good. We've known for a long time from Chris Rain's work that the PVRs are helpful. So if you have flat forefoot waveforms or flat toe waveforms, that's pretty severe ischemia. On the other hand, if you have pulsatile forefoot waveforms, you can usually get something like a transmetatarsal amputation to heal. So you got to use these all together in correlation with your clinical judgment. We have laser Doppler for SPP. We have transcutaneous oxygen, and I'll share a little bit on Indocyan and green, just because we've been trying to look at a way to follow these patients. Now, the second question, so you've measured it one time, why bother to remeasure it after you've done something? Well, one, let's prove that what you did really had an effect. Don't you want to know that whatever revascularization you did actually worked and how much it worked? Especially now that we sometimes decide to treat segments of disease and not go for broke. So when you have multi-level disease, it's sometimes a big deal to try to fix it all in one setting. So you try to fix the inflow first, general principle. You try to fix the most significant lesions, but it may be difficult to fix all that at once. So for a smaller foot wound, for example, you may not have to fix everything. So why not reassess the perfusion, see what happens, and decide if you need to do more based on those measurements and based on how the foot's responding. The other thing is we've noticed, and we've noticed this clinically for a long time, depending on the type of reconstruction, your blood flow doesn't always get maximized immediately, particularly like the case Miguel showed when you do a profunda reconstruction for rest pain, or you do a partial reconstruction of multi-level disease. You don't get the maximal perfusion benefit right away, and so we monitor these patients to see if we've actually gotten to where we need to get. And it may be a tool that you can use to try to figure out, rather than picking some arbitrary time after you've done a revascularization, to try to be more scientific about when you go back to cover the foot or do something to foot when you want to do it at the period when the blood flow is the best. So this indocyanine green is a vital dye that you inject it. And the advantage of that is a lot of our patients have renal failure. This is excreted in the biliary tract, so you can give it to patients with renal failure. We do this for research purposes. We don't bill patients for it, so we still do conventional measurements. But Dr. Jean showed you yesterday, we tried to come up with a correlate to the severe ischemia group on Wi-Fi, so those severe grade 3 ischemia patients. And we think we've started on that, and that's to identify these patients because they're most likely to be the ones that need revascularization. So this was the case of the heel ulcer Dr. Montero Baker showed you, and this guy had this heel wound for a long time, been total contact casted, hadn't healed, had lost all his toes before, and had a palpable dorsalis pedis pulse. And you can see here disease in the long TP trunk, perineal stenosis, and the posterior tibial I couldn't revascularize. So I reluctantly disfixed what I could, and you see all these heel collaterals, but if I'd been in a meeting and somebody showed me they now had these heel collaterals and things were much better, I'd been really skeptical. But look at the indocyanine greenangiogram. You go from very poor slope here before intervention. This was immediately afterwards, dramatically increased, and it lit up, and the patient's wound healed in 6 weeks. He had that wound for over a year. So that helps you decide what to do. Now this segues into the final part of the talk, is once you've decided there's a perfusion problem, then you start looking at anatomy. But anatomy by itself doesn't really give you the perfusion information. So this was a patient, I'll show you the rest of the angiogram before, but he didn't have a really good pedal target. He had this lesion in his below knee pop and anterior tibial artery. This is his foot, so the dorsalis pedis is occluded. You could probably bypass to this vessel, but it's a disadvantaged target. This is his toe waveform. So all we fixed, patient's foot wound. Did I show you that? Let's see here. I'll show you in a minute. He has a small foot wound, so wound ischemia grade, wound grade 1. So we angioplasty the anterior tibial artery and got a really good result. And this is immediately after, this is preoperative, so terrible slope, flat toe waveform, bad perfusion. This is it. This is a wound 1. So that's why I was trying to just fix a little something, because I thought that would be enough to heal the wound. Well, afterwards, it's not any better. That's pretty depressing. And we didn't embolize. It was a careful procedure. He had a good anterior tibial pulse. That was immediately afterwards. This is 24 hours afterwards. This is 48 hours afterwards. And dramatic improvement. So some of these patients where you can't revascularize everything, you need to wait a few days to see what you get. So the final part is look at the patient. So this patient, Dr. Andrus and I presented last year or the year before. We did an interview with her, and she'd failed angioplasty somewhere else. She had a TASC D occlusion. She was told she just needed to have an amputation because she was 82. Well, the lady was on one drug for hypertension, had normal cardiac function, gardened independently before she got foot wounds, and she had a great saphenous vein. So she had high functional status. And this just shows you her ABI was 0.36. Now, you don't need any other testing in her, but because we're trying to correlate, she had no foot pulse, ABI 0.36, TASC D occlusion. And so she had an anterior tibial bypass. And you can see how the correlation between the improvement in ABI, so it more than doubled. Her toe pressure went from 0 to 60, and her indocyanine green markedly improved. So we're not suggesting you do all these studies in every patient. What we're trying to do is be able to correlate indocyanine green with toe pressure and ABIs, so that in patients in whom you can't measure those, we have some other alternative. So I think because our patients have changed and the foot wounds we see are more complicated and it's hard to measure blood flow in diabetics, we need other means to measure it. In most series, at least 30% of patients are hard to measure or unreliably measured by conventional means. So if you want to treat these patients correctly, you should make blood flow measurement part of your preoperative routine assessment tool. After you revascularize people, they should be followed by surveillance. You need to reassess to be sure your revascularization is really, really effective. And one of the difficulties we've had on our own toe and flow unit where we share patients is the podiatrists assume that since we've done revascularization, it's immortal. And that patient's been revascularized and they must have normal blood flow. And we'll occasionally get patients, this is not to poke at the podiatrist, we're all working really hard, but everybody has their own part to play. So when the wound stalls or you get a recurrent wound, the first thing you need to think about is our perfusion still adequate? Just because we did something doesn't mean it's still working, so you need to reassess those patients. I think ICGA, so we have a research relationship with them. I have no financial relationship with them. I have no stock in this stuff, but I think it's another way to measure perfusion that's currently available. And some of the other methods you were shown today, a tattoo of some sort or some way to measure oxygen flow that we can monitor with a wand would be great. I don't think it matters what you use so much as the fact that you routinely use it, so it should be in your algorithm. So in conclusion, and actually I'll be on time, is pulse exam, history, and continuous wave Doppler on every patient, objectively measure the perfusion in some way, grade their perfusion, and then looking at the Wi-Fi framework and the rest of the patient and finally their anatomy. If the perfusion's not adequate to heal the wound, fix it. Once you've fixed it, reassess it to be sure you've really fixed it, and then follow that patient over time to be sure that your hemodynamic result has been adequate. So hemodynamics are important, so if you don't believe it, you need to keep measuring it. Thank you very much.